So this morning we moved from the lungs to the heart, and now we start with the airway. Thank you, Dr. Ammar, for inviting me to speak today. Thank you all for the organizing committee. I have nothing to disclose. We'll move from the introduction to the quick assessments and some tricks to assess the airway of patients, and then we'll move to some interesting clinical scenarios. So as pediatric specialists, we all know that children are far more vulnerable than adults, and I know because I practice airway in peds and adults. In adults, they tolerate, and peds, they plunge so quickly. The infant larynx is more anteriorly placed with more crowded cartilages within the larynx that is being said, giving a more complex anatomy of the airway. And in children, we have the problem of having syndromes that even can limit your access to the airway in terms of mouth opening, jaw protrusion, retrognathia, or even congenital masses. And as children, laryngeal mucosa is far more lax. Even simple infections can trigger severe edema that can precipitate airway distress. I think the first trick is to identify what is this noisy breathing sound that we hear, to differentiate between stridor, stertor, and wheeze. It's very important because not all noisy breathing is stridor. And as we know, infants are obligate nasal breathers, so even a simple nasal obstruction can precipitate airway distress in kids, and we can simply alleviate that by putting an oral airway. So the differences between those two sounds is that stridor is more of a monofilament noise. So while stertor originating from the nose has like a polyphasic waves to it. And the question is when to intervene. Do we have time to take history from parents, or should we intervene immediately? So the time frame is very important. A noisy breathing or a distress that progresses within hours or minutes means that we need to intervene now and ask later. While a noisy breathing that was since birth, taking a few months to progress, that noisy breathing you can take your history from the parents. And we quickly have to plot the child across the degrees of airway distress in terms of mild, moderate, and severe. We can simply see if the child is able to cry, is he still interested to play, like a quick seconds can make a difference to just plot the child into those different categories to know again, is there time to take a history exam, or we can just intervene immediately. The most important point I always tell our trainees, if a child came in distress, and then you notice that now he is becoming more quiet without an intervention, please make sure that the child is not already fatigued and not in the severe category. Because some will come back to me and say, oh no, the noisy breathing is far more less. Okay, is the child fatigued? This is a very important point. And as we said, the acuity of onset is very important. Like you can plot the differential diagnosis just by taking a simple, quick question as, did it come in hours, days, or chronic? And if you can see here that I have put I should put foreign body aspiration into hours, days, and chronic, because we can have children who aspirated a foreign body coming to you even months later with few months history of noisy breathing in a child who was not asthmatic before. So you should raise the question of having a foreign body aspiration. Generally speaking, infectious etiologies come in hours or days, while chronic pathologies are more of the congenital pathologies that we can see. And in the prenatal history, the birth of the child is very important point in the history. like history of prematurity. Was the child admitted to NICU? Was the child intubated? What was the size of the tube? Was there any reported difficulty in intubating that child, and why? Those are very important points that we can help us in guiding the diagnosis. And the precipitating factor, what makes it worse versus what makes it better. So respiratory distress that worsens with agitation, think of something that constricts the airway, and whenever the child is calm, he can breathe normally, or at least in a calm manner, while with crying, with agitation, no, it will become more. So think of something that constricts the airway. And a dynamic collapse is the one that worsens while supine, like malicious, or pathology within the oral oropharynx. Once the child is supine, it becomes worse. While a respiratory distress that worsens with feeds, again, think of malacia, because as we know, the coordination between swallowing and breathing is very important, and that's why it becomes more prominent with feeds. And the phase of respiration that the stridor comes with is again guiding us, whether it's inspiratory into the supraglottis, biphasic into the subglottis and glottis. So in our exam, a very useful tool to us is having the ability to do flexible laryngoscopy, where we can quickly assess the child bedside in a safely manner. And the preoperative diagnostic test, not all the time you have the chance to do it, because most of those tests, except a very useful tool, needs to be sent to another department. So what's that useful tool is the ultrasound. This is one of my publications about the airway ultrasonography findings in even diagnosing subglottic stenosis, where we can see the ultrasound is beautiful. It's a bedside tool, can give you lots of diagnosis, lots of information, where you can see the glottis. You can assess vocal cord mobility in patients with suspected paralysis. You can see the cricothyroid membrane, again, cricothyrotomy is not advised in pediatrics. And you can see the subglottis, and you can even take the diameter and correlate it even with the laryngoscopy findings in subglottic stenosis. So the airway is a shared organ between not only the surgeons, the anesthetists, the critical care. It's a shared organ. We have to always communicate our plan and preparation. What instruments do we need? What tools is available in your center? For example, you can find a very useful tool locked away in one of the offices, and no one is using it because no one is trained to do it. But so I think when you go to a new center, the most important is look at your resources, review everything in the store. Maybe you will find something useful. And always a very important note is to remember, before advancing in your management into a surgical airway, a very useful thought is to stop, think, go back and start again, because simple ventilation can save the child. I have faced a lot of scenarios where I found someone actually holding a blade ready to cut into a patient, and we just say, let's stop. I am an airway surgeon. I'm more than happy to cut, but let's go back to the basics. And if the child is ventilatable, that would save the child actually more than a blade. And again, knowing your tools, what pathology is best for a curved blade versus a straight blade, what tools do you have in your center is very important. Again, in communicating our plan, I find it very useful when the first person that looks into the airway just verbalize and like communicate what is the view that you're seeing in a direct laryngoscope before we even wait for a glidoscope to arrive or a CMAC to arrive. Like, the view is very important, because when they say we have a child with difficult intubation, I need to understand, were you able to see the airway versus were you able to see but I cannot intubate. Those are very different, because the tools that we will bring to help the situation will be different. And as we said, we have beautiful instruments, lots of instruments, of choices, but make sure what is available in your center. And always, I'm very important note is to remember, before advancing in your management into a surgical airway, a very useful thought is to stop, think, go back and start again, because simple ventilation can save the child. For example, why we say the positioning, some people would think it's like a minor step, but actually you can save a child by simply positioning them right, establishing the intubation pathway. So a very common pathology, especially in winter, is croup. And croup children, although they might appear simple, some of them are actually lost because of inability to intubate. As we said, the larynx mucosa is very lax, and simple infections can make the whole airway edematous and resistant to even pass a tube in. So a simple positioning, imagine if we're trying to push a curved or an angled tube into the airway, what will happen with the resistance? It will not pass. It will keep kinking at the oral cavity and oropharynx. While if we make everything straight and even put a rigid instruments inside the tube, you can, with corkscrewing, you can push the tube in. And I know that might sound scary, but actually we can help with edema later, but the most important is to establish the airway. And our anesthesia colleagues are the expert and even proceeding airway surgeons in terms of airway management, and they have those beautiful guidelines about the difficult intubation, what to do if the child had an unanticipated difficult intubation. And I think the most important variable here is cannot intubate, cannot ventilate versus cannot intubate but you can ventilate. Because as we said, going back to the basics, ventilating the child is actually what saved them. And this is again one of the publications in the emergency airway management. What we were trying to emphasize in this article is that the use, we are all in the digital time. So there are cognitive aids that if you can simply look it up or have it in actually in your center, just displayed or displaced in the emergency room, it would be very helpful, because those are like a quick reminders. We all know those information in the back of our minds, but in an emergency situation, sometimes we do have those momentary mental block. So just having a digital tool that you can look at, remember what are the things that you need for a cricothyrotomy is helpful. Those were for examples of some of the like a cheat sheet, as we call, to remind us of how to perform those critical procedures. And this is the tracheostomy emergency management algorithm, because all of us or some of us will think that once you have a trach in place, then the child is safe, but then you have the complications of tracheostomies. And previously we kept getting calls that child with trach getting obstructed, and actually we're not the first responders. We're not the frontline. Those important people, the frontline workers, they need again an algorithm to guide them. It's not actually fair for me to have follow this patient for a long period of time, and I know all those tricks about that specific patient, and then I leave that patient without a guide for the people who will actually be the ones to save that child. So, for example, if that child had a paper with him that says, this child cannot be intubated from above, this child has a grade 4 stenosis, this information will actually define the difference between a child who survived that event versus a child who might be lost. And we had a practitioner who tried to ever intubate a child and faced a difficult intubation, have the privilege to notify and actually alert in the file that this child is a difficult intubation and why. So we'll go to different quick scenarios. So we get a call you're on call today, we have a mother coming tomorrow, and she's going to deliver a child with this congenital malformation, which is simply a cervical mass, so be there on standby. And then we go ahead and we plan the exit procedure, which is to me a beautiful demonstration of how team collaborations can work, like by saving the mother, by saving the child, by having the intensivist, the surgeons, the anesthetist, the nursing team, the RT, all collaborating to save those patients. You can have simple cases where you get called into the emerge, where a child decides to eat a fried chicken in the middle of the night. Don't ask me why, they don't want you to sleep, and then you find this in their airway. I'm trying to write anyhow. Where you can simply use a very accessible tool, which is the Miguel forceps, to just simply pluck that foreign body away from the larynx. And thankfully, it got lodged into the mucosa, otherwise he would have aspirated it. So what about if the child was really distressed and become obtunded, and again the front line workers had a look with the airway and found that there is a foreign body actually lodged in the glottis. So please, we do not wait for anyone else to arrive. What we do is just simply use a Miguel forceps to actually push it into the trachea. If you cannot take it out, just push it in. Because the glottis, the subglottis is very narrow, the trachea is wide. So at least to allow the child to breathe. Again, that's a different patient where he was just recently extubated and recently discharged from PICU for some routine procedure. And then they call it in, the child came to ER distress. And again, with the scope, what do we find? We find a very huge subglottic cyst, which is a simple obstruction of mucous gland, and what we do is a very simple procedure where we just pluck that cyst away from the larynx. And the child was doing well afterward. And then we have a different patient where that patient was previously healthy, comes to the ER and having progressive respiratory distress over months, but the parents brought her while she was severely distressed. And like a disclosure, this was not the finding at her original presentation. It was far worse, where she got, alhamdulillah, lucky enough to have an expert emergency pediatrician who were actually able to find some air bubbles and intubate her into those air bubbles, where they, as they report, they could not even identify any single anatomy, except we're having a huge mass on the larynx and only simple air bubbles that they pushed the tube in blindly, and they said if she survived, she survived, because otherwise she was dying on table. And that patient ended up to have like a laryngeal papilloma, where she got more than 20 procedures in 1 year to just debulk those papillomas, and every time those papillomas will come back, and we ended up starting her on chemotherapy to just stop the recurrence, and now she's doing well, happily decannulated, and alhamdulillah. Thank you so much.